Respected chairpersons, friends, brothers, sisters, many thanks to the Scientific Committee Diabetes India for this opportunity. And we have been listening to the brilliant lectures on glycemic variability and on different dietetic patterns and its influence on the glycemic variability. And my responsibility will be to go through the journey of how to adjust and adopt therapies accordingly. These are my disclosures. Let me start off with a beautiful picture of a beautiful girl, and this is none other than Sierra, Miss Idaho, Miss USA, and she's proudly exposing her insulin pump over here as a symbol of her energy, enthusiasm, and her confidence despite being a type 1 diabetes subject. And the therapies based on insulin pump are one among those therapies which offer least or minimal glucose variability. Let me move on to a real life case scenario. This is Elizabeth, a 64-year-old lady who got newly enrolled in our center. History of diabetes since 14 years and with coronary artery disease of 1 year. And all these years, she claims that her A1C always been below 6, acceptable, and she was on statins, she was on antihypertensives, and all the numbers were within normal limits. And why she visited us? Her only issue was her mood swings. She was a troublemaker in the family. And she was attributing these mood swings to her diabetes. And we analyzed the existing baseline therapy, BMI, the values, the numbers are all normal, acceptable. We performed a continuous glucose monitoring for 7 days, and this was the pattern. Nocturnal hypoglycemia and profound variations in the glucose levels. Postprandial, both after the breakfast and then after the lunch. We advised her to shift over to a regimen of newer analogs and gliptins. And amazingly, not only the values, the numbers have come down without any hypoglycemia. Within 2 months of shifting the therapy, she reported tremendous improvement in her mood. And she is again back to a loving member, a respectful member of the family. And that's glycemic variability. In simple terms, the ups and downs in the glucose values. This is a geometric cube model as it appeared in the original Monnier article in Diabetes Science and Technology. And this is the representation of the glucose matrix. Along the x-axis, you have the fasting plasma glucose, and along the y-axis, you have the postprandial glucose value. And the base of this cube is formed by HbA1c. And you have an additional metric here, the mean amplitude of glucose excursions. And if you are to consider all these values and numbers together, they together will form this thick arrow, the oxidative stress and the resultant risk of complications of diabetes, especially the vascular complications of diabetes. And if you are to adopt therapies which will reduce all these numbers, ultimately you are going to bring down the size of the cube, thereby reducing the risk of complications of diabetes. And that's the importance of glycemic variability. And this is again back to Dr. Ciriello and his group. The studies that he has conducted. He has conducted studies with the help of euinsulinemic hyperglycemic clamps. And he had made use of subjects with type 2 diabetes and normal individuals. He maintained glucose values at 5 millimoles versus 15 millimoles per liter, alternating every 6 hours, continuously for a period of 24 hours. And in another subset of patients, in subjects, he maintained stable high glucose levels, measured endothelial function with flow-mediated dilatation, and oxidative stress with the help of 24 hours urinary excretion of 8-isoprostaglandin F2. And amazingly, he could prove that oscillating levels of glucose, in contrast to a stable high level of glucose, will result in oxidative stress, and thereby it is deleterious to the endothelium. It is responsible for the microvascular and probably macrovascular complications of diabetes. It enhances apoptosis, cell death. And what's the relationship between glucose variability and the risk of occurrence of hypoglycemia in clinical practice? And this is the data which shows increasing variability, that is a standard deviation. Higher the glucose variability, higher the risk of hypoglycemia, which is totally independent of ambient glucose levels. And below a magic number of a standard deviation of 1.7 millimoles, the risk of hypo is almost eliminated. And this is very important in clinical practice, to assess the risk of hypoglycemia, which is independent of the A1C levels and independent of the control of diabetes. This is the Indian data from our center, and this is in 63 type 2 diabetes patients, where from CGM we measured the standard deviation, mean amplitude of glycemic excursions, and the mean of daily difference. And we found therapies related to glycemic variability. We found higher the standard deviation, higher the dose of daily insulin. If you can keep the total daily of insulin low, you can keep the variability low. And glibenclamide will have more variability compared to glimepiride. And glucose variability very low with therapies such as with insulin pump. And this is how it will look like. In a type 2 diabetes patient on a variable basal profile with the help of an insulin pump, and if the pump is well programmed with the help of a CGM, and you will get almost a similar picture with the aid of the new GLP-1 RA-based therapy such as liraglutide. And you can have the aid of a continuous glucose monitoring, whatever be the baseline therapy in type 2 diabetes. And here is one paper from us on CGM as a tool for therapeutic decision making in type 2 diabetes. Adjusting therapies, adopting therapies, adjusting and adopting lifestyle modifications, etc. And this is the utility of CGM over the conventional gold standard of SMBG in making treatment changes in insulin requiring patients. And this is a study among 22 type 2 diabetes patients on different insulin regimens. And the following patterns were observed in the continuous glucose monitoring: wide glycemic excursions, the occurrence of nocturnal hypoglycemia, and post-hypoglycemic hyperglycemia, very common, and others like glycemic variability and a very quick postprandial spike, etc. This is an earlier data which we have presented and which appeared in diabetes on the use of alpha-glucosidase inhibitor in those with postprandial excursions. This is what we have discussed: the occurrence of post-breakfast spike, very classical of an Indian type 2 diabetes continuous glucose monitoring pattern for several reasons. And this is the action of acarbose baseline and at 3 months and at 6 months. This is pre-diabetes, another wide area where a continuous glucose monitoring will be of prolific significance. Here, the CGM will aid as a visual motivating tool for those with pre-diabetes. This is only an A1C of 5.9. However, the CGM is providing you with a pattern with glycemic excursions here and here, which cannot be detected during a routine glucose monitoring. And this is the importance of clinical utility of CGM in pre-diabetes and how your CGM and its visual appeal can impact on modifying the lifestyles to prevent the progression of pre-diabetes to diabetes. So this was a study which was presented at the ATTD, and it's there in Diabetes Technology and Therapeutic Journal. And this is the baseline A1C, and this is after 3 months, 5.4%. And you can see 99% of the glucose numbers within the normal range after 3 months. Another classical continuous glucose monitoring pattern, a post-breakfast and a post-dinner spike. And this is one patient who is already on optimal therapies. And these are the areas where you have to have your diabetes team members, especially the dietitian, to intervene, to be there in the team analyzing the CGM along with the diet pattern and the details provided by the patient and the caretaker. And she discovered a total of 2,200 calorie meal, and the patient was advised to shift to a 1,800 calorie meal plan. And this was a breakfast which was identified as an unhealthy breakfast, and the patient was advised to replace it with a low carb, low GI, nutritious breakfast. And this was a dinner menu which was replaced with a low carb, low GI, high fiber, balanced dinner. And this is the role of how the CGM will help you determine the number of profiles required, basal profiles required in an insulin pump patient, and how you can divide the numbers and the duration. And these are the CGMs available in the Indian market. Medtronic used to be a player for more than a decade. And CGMS Gold was the one which was introduced initially in India. And this is the iPro 2, which we are all familiar with. And this is a path-breaking innovation, which reached India hardly a week ago, and we started using this. And this is the picture of the first patient using the Freestyle Libre Pro. And I made a lecture today morning on Freestyle Libre Pro in the other lecture hall. And this is a CGM which is quite different from the other existing CGMs, which doesn't require a glucometer for calibration, which provides you a glucose value once in every 15 minutes, continuously for over a period of 14 days, versus other CGM, the Medtronic, which can provide you only for 6 or 7 days. And wireless, you can download the data at any time, first day or even second day. Need not wait for the CGM to be over. There is one more player in the Indian market, and that is Dexcom. And Dexcom has got a sensor which is quite different. And this is a comparison between the CGM sensors available in the Indian market. The iPro 2, the Enlight sensor, G4 Platinum, and Freestyle Libre. And this is the mean absolute related difference. The lower the mod, higher is supposed to be the accuracy with the sensors. But almost all of them are matching. And this is the frequency of the glucose readings. And this is a real-time reader. And we have a blinded reader at present available in India at an extremely low price. And this is the type of sensor technologies available. We have two types of technologies. One is the wired enzyme sensing technology, and the other one is a glucose oxidation method. Glucose oxidation method used to be the method which is followed by the Medtronic and by Dexcom, and it's based on the simple principle of interstitial glucose matching with the glucose in the capillary, and it is almost the same except for the lag time when it is fluctuating. And the platinum electrode is coated with glucose oxidase, and this is a chemical reaction at the end of which electrons are released, and these are sensed as the voltage and translated to interstitial glucose values, and this is the interstitial signal which is recorded by the recorder or transmitted over to the pump. In the wired enzyme sensing technology, which is patented by Abbott, it has got an excellent sensor stability. There is a reduced susceptibility to variations in vivo oxygen concentration. It is a direct technology. And there is a minimized response to common electroactive interference. And this is the direct method of wired enzyme technology. And I can download. This is one of our patients, and I have downloaded the CGM on the 8th day. And it will go on like this for 14 days. And the ambulatory glucose profile will start appearing from 5th day onwards. And obviously, it will provide you information which you can interpret and translate into clinical practice within minutes. And here you have the area prone for hypoglycemia. You have the median over here. And the shaded blue area is the interquartile range, the 25th and the 75th percentile. That is 50% of the glucose values, which are overnight, daily, and during the postprandial period. And why? Why this is important? Why are we having lot of glucose sensors now? Why should we require sensitive, accurate sensing continuously, subcutaneously? Are we going to replace the glucometers? The reason is we need such accurate sensors for the development of artificial pancreas. Artificial pancreas, in simple terms, is a combination of three components. It is a combination of glucose sensor and a transmitter, and you need the external insulin pump, and the barrier used to be the mathematical algorithm. That was the biggest barrier. The algorithm which can mathematically calculate based on the sensor data and tell you how much amount of insulin should be automatically delivered by the insulin pump. And this is a taxonomy of the artificial pancreas design. It's a very simple taxonomy. You have multiple inputs over here. You have the inputs coming from your sensor, not only the glucose sensor, but also the activity sensors, the heart rate monitors, and you can even manually decide on your glucose range. And you have multiple outputs here. In addition to insulin, you have glucagon, pramlintide, etc. And these were the algorithms, MPC, PID, and the fuzzy logic. The behavior of glucose in type 1 diabetes is fuzzy. And this is a fuzzy algorithm, specific and used in the new recent research for the invention of artificial pancreas. And these are the top leaders. Moshe Philip, Tadej Batilno, and Thomas Dane is already there. And they have invented the DREAM or the DREAM. And there is something new which has happened. That is the glucose test software. The software which has got a CE approval. It is approved in Europe. First time in the world. The artificial pancreas algorithm, the MD logic algorithm based on fuzzy logic, is approved. And just 4 days back, this is a milestone in the history of diabetes, Medtronic has partnered with the DREAMed for the introduction of artificial pancreas, and it's a dream come true. And this is Dr. Moshe Philip, the chairman of DREAM, the DREAMed Technologies, with one of the cute patients with artificial pancreas. Thank you so much for the opportunity, and thank you so much for the patient listening.